We'll call the meeting to order, and if you'd join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Dee, if you could call the roll.
Director Nicholson.
Present.
Director Stewart.
Present.
Director Wallace.
Present.
Director Danielson.
Present.
Director Eapen.
Present. Great. We're going to take the agenda a little bit out of order, and we're going to go immediately to the quality report with Mary Bowron.
Good evening. Thank you for making that accommodation. I appreciate it. This evening, we're going to be presenting the quality dashboard for quarter ending 12/16. So that is October, November, and December quality indicators. To start off with, our core measure compliance with our VTE continued to do really well on this. The last quarter, we met all of the metrics for the patients that needed to be educated on their blood thinner medication and made sure that all the interventions were made in the appropriate time that CMS requires them to be. We continue to have the same luck with stroke. Also, we've been doing really well there. The patients are being educated appropriately. We've been able to make sure that they were all assessed properly for rehab, and that their medications that prevent blood clots have also met all the standards. So again, above the benchmark there. So moving into our infection prevention indicators for CLABSI, for central line associated bloodstream infections, this we did see an increase. There were 3 that CMS expected us to have closer to 1, but we're just going back and doing a root cause analysis on each one of those to make sure that there was anything that there was done with the maintenance of the line, that we can take the appropriate interventions. And so we're looking at that, going back to reminding everybody to scrub the hubs. Of course, we'll continue to concentrate on hand hygiene. We don't think that this had anything to do with the placement of the lines on these 3 because the infections developed well after the time. So most of them were about 7 days after. So we'll continue to be monitoring that. C. difficile, we've had some good success here in the last quarter. We actually are at one of the lowest points we've been at in over a year. There are only 6 hospital-associated C. diff cases, which puts us actually below the national benchmark for a hospital of our size and type. So those were lower than expected. We're going to continue to do what we've been doing with the cleaning, antimicrobial stewardship, hand hygiene, all of that, looking at it from a bundled approach, and we'll continue to do that and monitor it. Catheter-associated urinary tract infections, did see an increase in this, and it was a significant one. We're actually higher than the benchmark. The benchmark is anything above the 1, and we're at a 2.1, and this was a total of 5 catheter-associated urinary tract infections. So when we recognized we had this data, we really wanted to look at seeing what could we do as an immediate action to try and bring this back down to where we've been at typically in the past. And one of the things is looking to get the device taken out as soon as possible. So if it doesn't have a medical necessity to be in there, we should be able to take it out. And one of the ways that across the nation you've seen hospitals have success is by implementing a nursing-driven protocol to remove catheters. Per the nurse, if the nurse looks at the case and of the patient and sees the national standards for why you can have in a urinary catheter, we want to make sure that a nurse has the ability to take it out without calling the doctor every single time. So we obviously had to get the physician approval to do this, and we took it to medicine committee, and they were very supportive, and they helped us write the protocol and the indications to make sure that they met the medical necessity. And so we're working on towards getting that implemented. And typically when a hospital implements that, their Foley cath days come down, and then of course the county does. So we'll watch and see if that's making a difference. We're just rolling it out and doing education and nursing right now. We did not have any hospital-acquired MRSA in the blood, putting us below the national average. And the same with VRE. We did not have any VRE in the blood. We continue to see a lot of success around the colon surgeries for surgical site infections. This is the 3rd quarter in a row that we haven't had any. And I was looking this up to see nationwide, sort of what percentage we are in. And we are absolutely in the top percentage of people who with hospitals that do not have colon surgeries. They actually listed out the number of hospitals in California. It's public data. And it was, it's a very few select. And so we've continued to do well in that area, which is good because this is one of the 2 surgical procedures that CMS requires that we report to them. In California, we have to report over 30 types of surgical procedures, but on a federal level, they only want to look at 2 for right now, and it's the colectomies and abdominal hysterectomies. And again, we went the 3rd quarter in a row with abdominal hysterectomies not having any surgical site infections. So we're happy with that. Moving on to the nursing sensitive indicators, hospital-acquired pressure ulcers continue to stay at a lower rate than what's expected by CalNOC. We looked at the pressure ulcers that are in the entire house on all units. If they're not documented on admission and we find it 24 hours after admission, we have to document it and call it a hospital-associated one. But that still is getting us at about 0.66, and the CalNOC benchmark for that is closer to 1.15. That was a total of 152 pressure ulcers for the entire quarter. And then for falls per patient days, we, out of the patient days is the 12,730, and we have been, with all the falls that we've had, have been remained underneath the benchmark again for this quarter. But what we really want to focus on is when people fell, was it an anticipated fall? Did we assess properly ahead of time and recognize that they needed to be on fall risk precautions? And if they did, were they injured? So this is the more important metric that we like to drill down on for falls. And we're sort of hovering right in here. This was actually, it didn't take much to put us right a little tad over the benchmark at 0.08. And that was because we actually had 2 falls, and one was in critical care, and it was anticipated both people were on falls precaution. But if they get any sort of a bruise or abrasion or even a skin tear, which was the case in these, it's actually considered an injury. But I always want to be careful to point out that this wasn't, it's not a head injury. There were no fractures in these cases or anything, but still something that we have to monitor. And our Joint Commission National Patient Safety Goals continue to do well with the handoff. We did, this is 99.7 because there was a unit in the hospital where when they were directly observed doing their handoff, their SBAR, the person did not mention the chief complaint. Of course, it was in Epic, and it was something that was obtainable for the oncoming shift, but we actually need to see that happen in the SBAR process, and it did not. So that's why that fell out. But otherwise, we were at 99.7% compliance. Patient identification did really well again, met at 100%. Procedure timeout, 99.9. That was 1. It was in an operational environment, and the timeout was charted, but again, during the direct observation, there was one piece of information left out, and it was the verification of patient ID, the second verification. So, but it was charted. Hand hygiene continued to do well at 97.9%. This is something that we've really tried to move towards getting people trained as observers, because what happens if you have the same people out there, especially members of infection prevention team, and they're always doing the same observation, then people start to change their behavior by recognizing who's out there doing it. So we just trained a whole new group. We have them out in hospital, and we've been able to really increase the number of observations. We had over 300 observations in this quarter, which was really good by having these extra trained people. Readmission rates, again, this is something that we're required to monitor through CMS. And in the first one is with the pneumonia. It continues to hover a bond. We had a little bit higher than the benchmark. We had 9 cases out of 42 patients that had the primary diagnosis of pneumonia came back. That puts us at 21.4, and CMS wants you to be closer to 17.1, so that still is a challenge. Heart failure readmissions, we did see an increase here. We had 18 of the 49 patients that were admitted with heart failure come back. This gives us a 36.7% compared to the national benchmark of 21.9. But when you drill down on these 18 cases, they count as 18 separate encounters. 5 of these encounters were actually the same patient, unfortunately. So, and it was somebody who really needed the medical management of an acute care setting. And so we were able to get him admitted, stabilize him, get the needs that he met with social workers, he had home health, he had everything, and unfortunately had multiple admissions that count as towards our readmission rate. heart attack readmission reductions. So we are, again, above the benchmark. 4 patients out of the 19 came back. None of these 4 patients came back with an AMI complication. It's just an all-cause. So it's that put us at 21.1%, and they're getting stricter on this, and it's at 16.8% compliance. So I think what we're going to continue to do with the readmissions is work with our clinical operations readmissions committee and sort of reevaluate. We're going to do some drill down on the data and look at all the causes of what brings people back and see where we can target our interventions moving forward. That's it. Any questions?
For Mary?
It's really nice to see that C. diff rate come down.
I know, we were really happy about that.
Let's hope it stays that way.
Yeah, I
Great.
agree.
Thank you very much, Mary. We'll now return to our regularly scheduled programming, and Nancy, if you could introduce our education session.
Happy to. We're going to be hearing a presentation by Dr. Eftemi. He joined UCSF as the co-medical director of our new UCSF Washington Cancer Center in January of 2017. He has a clear desire to bring exceptional cancer care to the community setting. He attended the University of California, Irvine, receiving a Bachelor of Arts degree in art history and a Bachelor of Science in biology. He earned his medical degree at Loma Linda University, where he completed a residency training in internal medicine, followed by serving as chief resident for internal medicine at Loma Linda's Veterans Affairs Hospital. He then completed a hematology-oncology fellowship at the University of California, San Diego, and is board certified in hematology and oncology. With that, I'd like to hand the program over to Dr. Eftemi.
Dr. Nichols, Nancy, the board, thank you very much for extending the invitation. On behalf of the UCSF Cancer Center, UCSF Washington Cancer Center, I should say, thank you very much again. You'll hear from my partner, Dr. David Lee, next month, but today I wanted to talk to you a little bit about the lecture that I gave a few weeks ago to another forum over here, and apparently it was received warmly, and I was asked to give it again. So the lecture really came out of the idea of what exactly are we doing besides trying to cure cancer. We have medications, we have surgeries, we have radiation, we can have colonoscopies, and we can have mammograms in trying to decrease the rates of cancer, but can we do something else? Can we do something more? And I wanted to look a little bit further into some of the ideas that we've known for many, many years, that a healthy lifestyle somehow may translate into better health, which then may translate into less cancer rates. So that's why I wanted to look a little bit into the relationship between genes, lifestyle, and the risk of cancer. So I'm going to start here with National Geographic. This was published in 2003, I believe, 2005 rather, and this is by Dan Buettner. And Dan Buettner was a journalist who received funding from the National Geographic to look at 5 particular spots in the whole world that actually had unusually high survival rates. And these were spots where people actually lived much longer than the average lifespan in the rest of the world, usually about 10 to 12 years longer than people around those areas. And those 5 areas, the original areas, were in Okinawa, Japan, on an island in Greece, Ikara, Greece, Sardinia in Italy, and in Costa Rica, as well as in the United States, it was actually Loma Linda. Is there something that I can point with? Oh, it's right next to me. Thank you. So, as you can imagine, going to Loma Linda University for medical school, this actually piqued my interest. This actually came out way after I finished my medical education over there, so I had moved away. But there were 9 particular reasons why he thought people actually over there live longer. And one of them had to do with downshift. People basically in those areas were less stressed. It had to do with purpose. People woke up and they actually had a purpose. They wanted to do something. Even people in their 90s, if they had something to do, they actually wanted to do it. And I'm not sure if people are familiar with the Terman study. I believe I'm pronouncing it correctly, but Professor Terman was a professor at Stanford in the early 1920s and 30s. And he took approximately 1,200 incoming freshmen to Stanford in the 1920s and 30s and followed them longitudinally for many, many years. And he was able to collect data on socioeconomic status, on health, as well as followed them through their lives. And of course, after he died, the Department of Psychology continued to do the study, and today it is the longest longitudinal study. And it's still going on today because there are still a few people still alive. But a few years back, they released the fourth or the fifth update to the study. So you can imagine this is decades of study. And the book that they released was actually what made people live long. And there was one particular thing. When they controlled for health, for socioeconomic status, there was one thing that made them live long. And there was actually a purpose in life. So people, even if they retired, if they continued to do something that gave them a purpose, those people on average actually live longer than people who didn't have that. So it actually parallels what Dan Buettner was able to find. The third one is actually a slanted plant-based diet. Notice it doesn't say vegetarian, it just actually says a plant-based diet. And this actually has to do with the fact that most of the people in these areas, with the exception of the people in Loma Linda, and I'll talk a little bit about them a little bit later on, they eat less meat than we eat here. On average, they eat maybe once or twice a serving of food per week, but it's mostly a plant-based diet. Wine at 5 o'clock, this we all can agree is a great thing. Then family first, which actually they do take it to heart. And in most of these areas, in Japan, in Greece, in Italy, in Costa Rica, not so much in California, but in all of these areas, because of the way the communities work, you actually have the grandparents, the parents, the kids, the grandkids, they all live in the same community or close by, so they are always together. The 80% rule, which is basically when you eat, try not to overstuff yourself. So when you think you're about 70, 80, 90% full, you just stop at that point. Move naturally. This doesn't say that you should actually join a club, but it's embedded into your lifestyle. A lot of walking. And of course, here in the United States, it's a little bit harder to do that because we're so dependent on cars and there's such great distances between where we live and where we work. But in those areas that were studied, that's how the communities naturally and organically grew. They're walking-based communities. The right tribe, and this actually describes the idea that you should surround yourself with people who support positive behaviors. It doesn't necessarily mean that you're always an optimist, and it doesn't say that you shouldn't be around pessimists, but you should be around people who overall have actually a realistic and good outlook on life. And the last one is actually belonging, and that's belonging to either a faith-based community or other non-faith-based communities, but actually belong to a group, something that actually gives you meaning. So I was looking at all of these 9 things, and my question was, can we actually find scientific data to show a link between why this is happening, why you have these things, and why people live longer if they do these things? So, of course, you have the common knowledge. We all know if you eat well and you have physical movement and you have family and friends, you have a long life. I mean, we can all agree this is kind of common sense. We understand that. We have the observational studies which show that people who do these things actually live a longer life. But the question is there a scientific data to explain why these occur? And we have some scientific data for some of them, but not for all of them. And I want to switch gears for a second and introduce to you Dr. Elizabeth Blackburn. She's actually at UCSF, has been there since the early 90s. Prior to that, she had been at UC Berkeley, but she actually received the Nobel Prize in 2009 for physiology and medicine for the discovery of telomeres and telomerase. And what exactly are those things? Well, biologically, the way we grow is that you take a cell, and that cell actually cleaves itself in two and creates two brand new cells. That's how we grow. We don't have a mother cell that does daughter cells. It doesn't work like that. It's actually one cell becomes two. When that happens, we actually have chromosomes that basically have to divide. You can't take the chromosomes from one cell and divide them in two and expect to have the same thing. You actually have to multiply your number of chromosomes. Once you have double the amount of chromosomes, then you can actually cleave and form two cells. In the process of the replication, it was noticed that at the ends of the chromosomes, you actually have this area called telomere. And every time you multiply your chromosome, a little bit of the telomere gets snipped off. So you can think of it as a shoelace, and you have the plastic thing at the top of the tip of the shoelace. I don't know what that's called, but that's the telomere. And it gets cut, and it gets cut, and it gets cut, and it gets cut. And then what happens is that if it gets cut too much, what happens is that you start cutting into real DNA, because the telomere is nothing but just gobbledygook. It's just garbage. It's basically base pairs that mean nothing. There's no genetic information there. And this is the way to maintain integrity of the DNA, because when the DNA replicates, you always snip off a few base pairs at the very end. And the way we're made is that the telomere prevents the real DNA from getting snipped off. So this is actually from the U.S. Department of Energy. The bright dots over here, these are the telomeres. So what happens is that the question became, after this was discovered, and Dr. Blackburn and her colleague described it, the question was, is there a relationship between telomere length and how long we live? Because the supposition is that if your telomeres are very short and your DNA gets damaged, then you probably are not going to live as long. And observationally, it actually holds true. This is from 2003 in Lancet, and it turns out that people who were 60 to 74 years old, if they have longer telomeres, their longevity was actually higher than people who had shorter telomeres. And it goes the same thing for people who are ages 75 and older. The longer the telomere you had, the higher chance, the higher likelihood was that you're going to be alive later on in life. So now we have an observational study which shows that there is a link between telomere length and longevity. Consequently, the consequence of the short telomeres is that if it's too critically short, the cells, they cease to multiply. You actually have an increase in pro-inflammatory cytokines. Basically, the body goes into a fight or flight mode. You have loss of antigen recognition, and all this means is that your immune system surveillance ceases to work the way it should. Because our immune system is able to control our body, and anytime there's a DNA damage, which happens on a daily basis, the immune system is able to say, aha, I'm going to take that cell out of commission. If the immune system is not working properly, then you can actually have an increased rate of many things, including cancer. We know that short telomeres can lead to artery disease, to coronary artery disease, diabetes, and early mortality. Can it lead to cancer? So this is actually a very simplistic way of looking at it, but this is actually based in science. This is the normal evolution as we understand it today from a normal breast cell to breast cancer. And it goes through a normal pattern, then you have hyperplasia, which means that cells multiply, then you have a carcinoma in situ, which is a precursor to active cancer, and you have actually proper cancer. When you measure the telomere length on these cells, you can actually see this red line. This is the length of the telomere, and it shows you a representation of how the telomere length actually decreases as you go from a normal to a pathogenic problem, which actually leads to cancer. So, fine, we know that people who have short telomeres don't live as long. What about people who have cancer or who have short telomeres? Can we see a relationship between the two? This was actually published in 2010. And basically, they looked at people over a period of 20 years of their telomere length as well as the incidence of cancer. And you can actually see here that the shorter the telomere, this line over here shows long telomeres, this line over here shows short telomeres. The higher line shows you that there's a higher incidence of cancer in patients in people who have short telomeres, and not so much in people who have long telomeres. So we're actually beginning to get a proof of concept that short telomeres could actually be associated with increased incidence of cancer. So the question is, that's fine, that's great, but can we do anything about it? So I'm going to introduce you to somebody else called Dean Ornish. And Dr. Dean Ornish is also on the clinical faculty at UCSF. He also has an institute, it's called the Preventive Medicine Research Institute. And a few years back, he actually promulgated and came together with a lifestyle program called the Dean Ornish Lifestyle and Diet. And it happens to be that Medicare, initially this was the only diet program that Medicare paid for. And you know how stingy Medicare is with paying for things? So this was actually the first program to show that people who undertook it, their coronary artery disease rates were reversed. And what does this lifestyle medicine is all about? Is what you eat, is how you manage stress, it's how much love and support you have, and how much you move. Do you see a connection between this and the blue zones? It's a similar thing. So what exactly is it? The diet. It's mostly a plant-based diet, and I have to say that when you go to the Dean Ornish diet site, very few people will be able to do this for a very long term, because it's strict vegan, and even avocados are kind of persona non grata over there. So, but he recognizes that, and it's not about that. It's about the idea that you're trying to improve your diet. But it is very high in plant-based protein, fruits, vegetables, low in fat. Actually, less than 10% of calories come from fat. Moderate aerobic exercise, and for him, that's 30 minutes of walking per day for 6 days a week. Stress management, which is about 60 minutes daily, that can include gentle yoga-based stretch, breathing, or meditation, or any other thing that actually calms you down. And then you have increased social support, weekly support group sessions, but it can include anything. It can include spending time with your family, as long as your family is worth spending time with. I have an 11, 8, and 2-year-old, and sometimes I wish I were on call. So unfortunately, this was a problem with the formatting, but I wanted to show you over here where we actually had 30 men with biopsy-diagnosed low-risk prostate cancer. And all they did, they went on an Ornish-style lifestyle for 3 months. That's all they did. And then they measured the telomere length before and after. And actually, all of them had an increase in the length of their telomeres. So this was back in 2008. So this was a proof of concept, and I will show you a follow-up later on what happened to those patients. So what have we learned so far? Is that with the Ornish diet, if you have a plant slant, if you move naturally, if you downshift, you actually may get some benefit in terms of increasing your telomere length. And 5 years later, they had a follow-up of those patients. And these were the 35 men with biopsy-proven low-risk prostate cancer. But this time, what they did, they said, okay, a group of you will continue with the Ornish lifestyle in as much as you can do it. I'll tell you, the diet portion of Ornish diet is not so easy. But 25 of them were actually controls. And they looked at their telomere length. And really, let me just spell it out for you. Patients who stayed on the Ornish diet had greater telomere length increase than patients who didn't. And actually, their telomere lengths increased by about 10% in the patients who actually had the lifestyle changes. In the control group, about 3%, the telomere lengths actually decreased by about 3%. So that's fine. So we know that cancer can shorten the telomeres. We know that Ornish lifestyle can increase the telomeres. But what about, we talked about plant-based diet, we talked about exercise, but what about stress? And I know nobody's stressed here in California. I mean, we are the most laid-back people, at least that's what people say about California. But then I moved to the Bay Area and I realized that, why is everybody so stressed around here? Everybody's just on the go, 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 So Dr. Blackburn, actually, the one who discovered the telomere, who described the telomere, I should say, and got the Nobel Prize, she actually looked, and her team, early in 2004, she looked at 39 mothers, and these were premenopausal mothers, and half of them had kids that had no medical problems. And half of them had kids with chronic illnesses. And if you're a parent, you know that when your kid is ill, it's not fun at all. You worry all the time. You do everything you can so your kid doesn't have to suffer, and you're always, always, always under stress. So she wanted to see what was the difference in telomere length between these two groups. And it turns out that the high-stress women, the ones that had kids with chronic illnesses, sure enough, they had shorter telomeres. And recall, these are premenopausal women. These are women in their 20s and 30s and 40s. These are young people. They have shorter telomeres. Low-stress mothers had actually higher telomeres. So the question is, fine, you have that, but can we increase the telomeres by doing something else? And we know that eating a plant-based diet can increase that because we looked at the Ornish diet. But what about doing exercise? Can we reverse the causes of stress-induced telomere length? And this is basically Dr. Blackburn again. This was in 2010, so 6 years later. They looked at 62 postmenopausal women. And this time, these were women who were caring for their spouses who had dementia. And if you know anybody or you've had experience with loved ones having dementia, it is really hard. Because health-wise, they're fine. But mental, they're not. And if it's an advanced dementia, the loved one that you used to know, they're not there anymore. And that's extremely stressful. So they wanted to see, for these women, if they actually exercised, we know that they're going to be stressed, right? They're taking care of a very highly stressful situation. But if they exercise, can we reverse that? And I'll spill the beans. Yes, they do. This is a very hard graph to interpret, but to understand. But essentially, women who exercised, which is actually women here in this line, they actually had longer telomere length compared to when they were just in the beginning. So now we've talked about telomeres. That's fine, but that's only one thing that we have some scientific proof that can actually help us live a little bit longer and a little bit healthier. But what about our genes? Can those 9 things that Dan Buettner was talking about, exercise, belonging, wine, yoga, all that, can those actually influence how our genes get turned on and turned off? And for that, I need to give you a little bit of a primer of tumor suppressor genes. So tumor suppressor genes are genes that actually turn on for a specific purpose. It's actually to block another gene from turning on. And the idea of how cancer happens nowadays is called the 2-hit hypothesis, which is 2 genes have to be deranged in order for cancer to occur. And those 2 genes, you actually have over here in this cartoon, you have a car, which is a normal car, and it's a normal DNA. And you have a tumor suppressor gene, and this car will not hit the wall because the tumor suppressor gene is going to put the brakes on this car. On this one, you have an active oncogene, and you have a tumor suppressor gene that works correctly. Well, an active oncogene is actually a gene that can produce cancer. That's exactly what it says, oncogene. But because you have a tumor suppressor gene that puts on the brakes, even though you have a turned on oncogene, nothing happens. That car will not hit the wall. But if you actually have a mutation in both an oncogene and a tumor suppressor gene, the DNA goes forward and cancer happens. The car hits the wall. So the question here is, we want to decrease the expression of oncogenes, and we want to increase the expression of tumor suppressor genes. So this is actually from UCSF as well. I have to give thanks to Dr. Peter Carroll from UCSF, from the department, and Dr. Chan from the Department of Urology. But this is actually patients with prostate cancer, and they divided them in two groups, those that did exercise and those that didn't. And then if you look at this panel over here, you can see a predominant green. And if you look on this panel, you see predominant green. And if you look over here, you see predominant red, and here's predominant red. Red means that the genes are turned on. Green means that the genes are turned off. Over here on the side, it shows you the top portion is actually genes that are good. And this over here are quote-unquote genes that are bad. So in patients who exercise more than 3 hours per week, they had an increased expression of the good genes, and they had the decreased expression of the bad genes. The corollary to that is that patients who had decreased exercise actually had a decreased expression of the good genes and increased expression of the bad genes. So this is yet more proof that exercise is doing something. We're beginning to kind of see a picture, but it's still a very murky picture. But we're getting to see that exercise has an unusual benefit, not only for making us feel good and mentally feel good, but also at the cellular level, at the genetic level, turning on and off the genes. So, cellular changes in response to lifestyle modifications include telomere length increase, which of course that leads to a potential longer lifespan. Upregulating good genes, so good genes are turning on. Downregulating bad genes, meaning bad genes are turned off. And then the last one is actually epigenetic changes. So what exactly is an epigenetic change? An epigenetic change is basically, it's a study of the heritable but reversible changes in gene expression. This occurs without alterations in the sequence of underlying DNA. That's a lot of words. What exactly does that mean? So my piano teacher, she came to the United States when I was 18, and I came to the United States when I was 14. My piano teacher has 2 daughters, and at that time the daughters were about 7 or 8. So I started taking piano lessons with her, and I was mediocre at best before I started with her. She was an amazing piano teacher, but her daughters, who were only 6 or 7, were amazing pianists, just amazing. I mean, their talent was off the charts. And then I noticed in other musicians as well, their kids, more often than not, are better musicians than my kids. And then you look at people who are really good in math, PhDs in math or physics. Their kids, for some reason, have an innate ability to actually do math-like things. And it goes on, so on and so forth. But those changes are not in the gene, in the genome that you inherit, but there's something else. And actually, a few years back, in the Scientific American, it was published that epigenetic changes, these are changes that occur in our lifespan to our genome, to our DNA, but it doesn't get transmitted as a genetic change. But these changes can actually be passed on to our sons and daughters. Well, you can't find it in a gene, but you actually find it in an epigenetic change. And what exactly does that mean? So our DNA, you can think of it as a string. And the string actually turns onto itself, and then it actually coils onto itself. And then it coils one more time, And then you actually put it around these big wheels called histones. So you turn it one more time because we have a very long DNA strand and it needs to fit in a very small cell. What happens is that at the end of the histones, on top of them, you have these groups that are called methyl groups, which is basically carbon and hydrogen. So these methyl groups become the backbone of the DNA. If you have too many methyl groups, it's like the barnacles on the bottom of a sailboat. They actually will not allow the sailboat to go very fast. Those methyl groups will actually decrease the chances of that DNA unfolding and actually multiplying itself. So those are called epigenetic changes. And what happens is that you have genetics and you have epigenetics. And epigenetics is something that you do after you're born. You get too many methyl groups on the backbone of the DNA. Genetics is something that you inherit from your parents. If you have instability on either genetics or epigenetics or both, this can actually lead to cancer. So how can genetics lead to cancer? Well, we talked about it, right? We talked about the two-hit hypothesis. If both genes are deranged, you get cancer. But what about epigenetics? And DNA methylation is something that quickly I wanted to tell you, which is the methyl groups attaching to the DNA. So what can we do about it? Because I won't tell you what the problem is unless I tell you what I think the solution might be. And it's actually dietary phytochemicals. And these actually have shown potential for modulating all major epigenetic pathways. The DNA methylation is actually one of the more important ones. So what exactly can phytochemicals do and where do you find them? Well, green tea, turmeric, grapes, soybeans, broccoli, cabbage, kale, cauliflower. I mean, do you guys recognize some of these things? You know, it's people have been telling you for years, maybe you should eat turmeric. Now, I'm not saying you should go out and eat turmeric and, eat too much, but there's actually a proof of concept that some of these plant-based phytochemicals actually do act against the oncogenes. So, for example, here it shows you on this side all the genes that we have seen that are involved with cancer. These are genetic pathways. And for example, in green tea, it actually upregulates the P16 pathway, which is actually something that can decrease the chances of cancer. So this is just a representation of phytochemicals. Of course, tomatoes, you have apples, you have soybeans, you have coffee, you have citrus, garlic, grapes, nuts, cinnamon, tea. So you can actually see that of those 9 things that we talked about, the blue zones, one of them was a plant-based diet. There's a beginning of a proof of concept at the biochemical level of how this can actually influence us. So again, these are the 5 zones. And I quickly wanted to show you that each zone is a little bit different. So in Okinawa, Japan, when the kids are born, from the very, very beginning, they are placed in a cohort, in a group of kids of the same age. It's usually between 5 and 10, and they will continue to be together for the rest of their lives. They're not their family, they're not their cousins, they're actually strangers in the beginning, but by the end, they become the closest that we can. And there is a documentary that I saw about Anthony Bourdain. It's the Food Network that he talks about. I forget the name of it, but in this one particular episode, he was actually talking to a Japanese noodle maker. And for the whole half an hour, it's about him. And he actually went with Japanese noodle maker because he had an important appointment to keep where he was born. And actually the appointment was to meet up with his friends, and they're all in their 80s. And this is what he was doing. That's why he said, I'm not going to talk to you. You can follow me, but I need to take the train. I need to go back home because I need to meet with my people. That's what I do. This is the strong sense of belonging in community that they have an amazing one of. In Greece, they specifically about them, this is the Mediterranean lifestyle. They actually nap during the day. And today I was talking to one of my patients who said he went home yesterday after the hospital, and because he couldn't sleep in the hospital very well, he went home and he took a 3-hour nap. And I said, boy, wouldn't that be wonderful if we can all take a 3-hour nap every day? Well, these people do it. These people do it. And their stress rates are actually much lower than it is for us. In Sardinia, Italy, they actually have daily wine, and their community, if you've been to Sardinia, which I haven't, but I've seen pictures, I mean, their homes are not very big. And it's grandpa, great-grandpa, parents, kids, I mean, they're all together, and there's no way that you can build a wonderful relationship. At times it's going to be very fraught with a lot of anxiety and angst. We all know how families are, but for the most part, they're not like that. In Costa Rica, they actually walk a lot, but also here they say that the water is naturally rich in calcium and magnesium, which may help prevent problems with bones. And then Loma Linda, California. I know a lot about these people because I'm one of them. This is actually Seventh-day Adventist. So Loma Linda, California has one of the highest concentration of Seventh-day Adventists. And Seventh-day Adventists are, it's a offshoot of the Protestant religion. And they believe mostly in a vegetarian diet. Smoking is very frowned upon. There's no drinking. That's very frowned upon as well. So kind of boring people. But I'm one of them. I can say that. But what happens is that they have two things they have three things out of the 9 things that we talked about. And one of them is a sense of belonging. So every Saturday, it's church time. So much so that Loma Linda, California is one of the few communities in the whole United States where the postal service does not work on a Saturday. They actually will deliver the mail on a Sunday. So on Saturday, the whole city shuts down, and we all go to church. And we spend most of the day at church, and it's a sense of community. Number one. Number two, they're vegetarian, although lately there's been a lot of cheese, and that can counteract the effects of the low-fat diet. And number 3, they walk a lot. So Loma Linda is still small enough that you can actually walk from one end to another. So I wanted to end a little bit here with a paragraph from the Blue Zones from Dan Buettner, which basically tells you what the diet of the Grecians on the island of Ikara consists of. At breakfast, they have goat's milk, wine, sage tea, or coffee. I mean, who has wine at breakfast? How wonderful is that? Nancy, can we get wine in the cafeteria? Honey and bread. Lunch was almost always beans, lentils, garbanzos, potatoes, greens, fennel, dandelion, or a spinach-like green called horta, which grows all over the place on that island, and whatever seasonal vegetables the garden produced. Dinner was bread and goat's milk. They also drank warm beverages called mountain tea, made from dried herbs endemic to the island, a rotating seasonal list that includes wild marjoram, sage, mint, and dandelion leaves. You know what? It actually includes a lot of these things. So in this particular situation, here you have people who don't try to be healthy because this is their lifestyle. They're not changing anything. That's what they learn from their parents, and that's what they do. So far, what do we know? If you actually are less stressed, if you have a purpose, if you eat more of a plant-based diet, if you don't have to drink. It's not the drinking that really counts, it's actually what drinking engenders, which is a time when you slow down and you actually relax and try to unwind. That's what it's a surrogate for. Family first, meaning you take time, actually meaningful time to spend time with your family. The 80% rule, don't eat too much, you move naturally. Notice how none of the people that I talked about are people who actually exercise for the sake of exercising. They actually just moved because they had to move. They were walking. The right tribe, and then of course belonging to a faith. So I'm hoping that through this lecture, I have shown you that lifestyle changes such as a plant-based diet, more physical movement, decreased stress, belonging, and a pursuit of happiness can actually slow down the shortening of telomeres. They can increase the telomere length. It can reverse the epigenetic changes that we acquire through our lives. That we can change the genetic expression profile where more good genes are turned on and more bad genes are turned off. That this potentially could lead to healthier, longer, and more meaningful life. It may not lead to a healthier or longer life, but I can tell you that it can lead to a more meaningful life. Thank you very much. And any questions? I would be more than
Any
happy
questions?
to.
Great lecture.
Yeah.
Fun,
Thank you.
fun to hear.
Appreciate it. Food for thought, maybe for action.
Thank you.
Okay, we've got consideration of the minutes for March 8, 22nd and 27th. If I could have a motion.
So moved.
Second.
We have a motion and a second. Dee, can you call the roll?
Director Nicholson?
Aye?
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eapen?
Okay, minutes are approved. Any oral communications? Seeing none, we'll go to written communications, which is Dr. Achanta.
Thank you, Dr. Nicholson. For the month of March, the Credentials Committee saw new applicants from 7 new applicants. Timur Anwar, MD in Interventional Radiology. Shilpa Shetty, Maternal and Fetal Medicine, MD. Jacqueline Chu, MD, Maternal and Fetal Medicine. James Fields, MD, Internal Medicine. Cindy Lau, Physician Assistant with Hematology and Oncology. Jalriza Mansouri, MD in OBGYN Oncology. And Brian Shea, MD in Hematology Oncology. Temporary privileges were requested by Timur Anwar, MD, Jacqueline Chu, MD, David Lee, MD, Cindy Lau, MD, and Jalriza Mansouri, MD. I'm sorry, Cindy Lau is a physician assistant. Yeah. Reappointment applications. Ibrahim Amadi, MD, Family Medicine. Muni Barish, MD, Infectious Diseases. Victor Maceda, MD, Family Medicine. Neeta Patel, MD, OBGYN. Robert Pipkin, MD, Cardiothoracic Surgery. Aruna Reddy, MD, Radiation Oncology. Charan Singh, MD, Neurology. Meena Tandon, MD, Pathology. Dale Taylor, MD, Otolaryngology or ENT. Joseph Zamuro, DO, Family Medicine. Milford Zaslow, MD, Anesthesiology, were the reapplicants. Transfer of staff category, Dr. Ibrahim Amadi, MD, Family Medicine, is moving from active to ambulatory. Dr. David Lee, MD, Hematology Oncology, is moving from provisional ambulatory to provisional active. Joseph Zamuro, MD, Family Medicine, is moving from active to ambulatory as well. Completion of proctorship and advancement of staff category, Nahid Rostami, MD in neonatology, has completed proctorship and has been on staff for a year, so he's moving on from provisional to active. Completion of proctorship prior to eligibility of advancement, Bethany Woomer, MD Pediatrics, will remain as provisional till she completes a year on medical staff. New privilege requests, Dr. David Lee, Hematology Oncology, has requested privileges in Hematology Oncology Core on the inpatient side. Withdrawal of applications, Joshua Ninichuk, PA, and Alicia War, PA, both withdrew their applications. Resignations, Samira Alibandi, MD Pediatrics, is no longer practicing at Washington. Judith Ashuri, MD Internal Medicine, same reason. Hector Bonilla, MD Infectious Disease, and Leslie Lush, MD Neonatology. They're all moved on from Washington to other locations. And that's the credentials for this month.
Achanta, do we have a motion for approval of the credentialing action items?
Move for approval as presented.
Thank you. Do we have a second?
Second.
Second. We have a motion and a second. Dee, if you could call the roll.
Director Nicholson,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Danielson,
Aye.
Director Eapen.
Great. Thank you. Motion passes. The credentialing action items are approved. Sure. Service League report. Debbie.
Hi, good evening, everyone. Just kind of give you a little bit of a heads up. First of all, we have coming up the Masquerade Jewelry Sale. That's going to be May 1st, 2nd, and 3rd. And hope everybody is able to come and support the Service League and this fundraiser that we have twice a year. It's important, and there's a lot of hard work that goes into it. And Cherie Gramato, who's our coordinator on this and chairperson, she works tirelessly. So we're trying to get the word out there, so we have hope we have a really good turnout. The other thing is that the board met on Monday at my board meeting, and we've just approved a new staffing assignment for the when the high census was going on during the year. Well, now we're going to be able to have volunteers to be up there on a regular basis to be able to help the different floors, and they will determine how many volunteers on each floor. I'm thinking one to start with if we can, but it's really going to open up a lot of opportunity for our volunteers over 18 who especially want to go into the medical field. I think to be able to be more hands-on, not obviously with patient care, but just to be there and see the environment and be there to help support the staff in any way that they need. We have staffing assignment has been established for this to meet the criteria and stay within the boundaries for the volunteers as well. Our Magic Hanky Pinky Puppet ladies, we've had some increase in membership there, which is nice because it was kind of getting slow a little bit. And a lot of the ladies had been left the area, so we've gotten 3 new members, and it was really nice on Monday when I went in there and saw so many people there and supporting this very important step. The other thing is the gift shop's coming along, and it's got new merchandise finally. So please stop in. Your support means a lot to us because we work tirelessly to try to make it special. And lots of new snacks have come in, trying to kind of reach out to all various areas, and we have some healthy things in there too, trying very hard. Another thing is attended the quarterly foundation meeting. And it was nice to hear the report today from the calendar. From the doctor. He did that at the foundation meeting, and it was very, very interesting. Another thing is that we have said we would staff the infusion center, and obviously this is his specialty as well. And we are really having a challenge in trying to get volunteers to do this because I really feel. For me, I was doing it, and I've had to kind of step away a little bit for the last month because my time is just very, very time busy. But I really want to get back to it because it's such an important, and if I could reach out to the volunteers to do this. A regular assignment, it's so needed, and I've talked to some of the nurses there, and they really work tirelessly, and it's very important to be there for our patients and to give them that little bit TLC and to help the nursing staff. What else has been going on? Just keeping busy. I think I met that criteria on one of those when he was talking about it. But it's a joy, and I just that's pretty much covers it at this point. So I want to thank you. Thanks for all of your support, too, of the gift shop. It means a lot.
Thank you, Debbie. We look forward to the sale, and it's good to see the expansion of services that you're providing.
Yes, that's my intention. It's pulling between president and gift shop manager, but it's important to keep. We got to look to the future, and that's something that I will be addressing in the near future because we need to.
Great. Thank you so much.
You're welcome. My pleasure.
Okay, Dr. Achanta, again, medical staff report.
Sir, medical staff continues to stay robust. We have 594 members on staff, 349 of which are in the active category, 3 in the administrative category, 17 allied health professionals, 85 ambulatory physicians, 4 in the consulting capacity, 29 in the courtesy capacity, 1 locum tenens. We have 73 provisional active, so strong bullpen, so to speak. And we have 15 provisional active allied health professionals. So our allied health professional group is going to balloon very quickly, almost double, when all of these 15 allied health professionals come on board as active. Provisional active ambulatory, we have 2. Provisional consulting, we have 5. And provisional courtesy, we have 4. And provisional temporary, we have 6. So altogether, we have 594 members on the medical staff.
Incredible.
Continues to grow.
Yep. Keep us busy and keep us active.
Yeah.
Gives us a purpose. Going off.
Just when do you downshift? I think I saw you taking a nap in the this morning.
Yes.
That was good. That was good. All right, we'll move on to our hospital calendar. Nancy?
Okay, we'll start with our video.
Past health promotions and outreach events. On Saturday, March 11th, Washington Hospital hosted Stroke Awareness Day. This free event screened community members for carotid artery blockage, atrial fibrillation, as well as cholesterol, blood sugar, and blood pressure screenings. The event was staffed by Dr. Ashjane, cardiologist, who provided results interpretation along with Washington Hospital personnel. Volunteers from San Jose State School of Nursing and the Washington Hospital Service League also assisted to make this event a success. The event was co-sponsored by Fremont Bank Foundation. There were 88 community members screened. Of those 88, 12 were found to have mild blockages, 6 were found to have atrial fibrillation, and 23 others were found to be at high risk for stroke based on other risk factors. On Monday, March 13th, as part of the Speakers Bureau program, Maggie Gooding, RD, presented Nutrition and Cooking for Brain Health to Fremont, Union City, and Newark Senior Commissioners at the Newark Senior Center. 32 people attended. On Tuesday, March 21st, Dr. Vijaya Dudiala, Internal Medicine, presented Strategies to Help Lower Your Cholesterol and Blood Pressure. 45 people attended. On Tuesday, April 11th, Washington Hospital hosted a seminar for community physicians focused on new cancer collaboration between Washington and UCSF Health. This event was an opportunity to celebrate the opening of the UCSF Washington Cancer Center, which is located on the Washington Hospital campus. The center's medical co-directors are hematologist-oncologist Bogdan Eptimia and David Lee, who are providing medical oncology patients with access to the latest technology, treatment, and research right in the community. At this seminar, UCSF Helen Diller Family Comprehensive Cancer Center's president, Alan Ashworth, talked about the future of oncology, the impact of precision medicine. Upcoming health promotions and community outreach events. On Thursday, April 13th, from 3 to 5 p.m., Sharmi Mukherjee, physical therapist, will present Balance and Falls Prevention. On Thursday, April 20th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, will present Difficult Conversations, Tips on How to Talk to Your Healthcare Provider. On Wednesday, April 26th, from 1 to 3 p.m., Dr. Stacy Berry, gynecologist, will present Solutions for Weight Management. On Saturday, April 29th, from 10 a.m. to 2 p.m., Washington Hospital will host the 11th Annual Women's Health Conference. This event will feature topics such as nutrition, heart health, and the benefits of meditation, in addition to a special presentation by Leslie D. Michelson, author of The Patient's Playbook, who will be sharing life-saving strategies and decision-making tools that patients and family members can use to become savvy healthcare consumers. Fee to register is $25. To register, call 510-608-1301. On Tuesday, May 2nd, from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ashjane, cardiologist, and Melissa Reyes, RN, will present Stroke Prevention and Other Disease Processes, Healthy Lifestyle, Be Smart and Avoid Stroke. On Thursday, May 4th, from 3 to 5 p.m., Dr. Vandana Sharma, oncologist, will present Early Detection and Prevention of Female Cancers. Also on Thursday, May 4th, Washington Sports Medicine will provide athletic trainers and host a first aid booth at the Special Olympics basketball tournament at James Logan High School in Union City. Next, on Thursday, May 4th, from 7 to 8 p.m., as part of the Diabetes Matters series, Plumi Granada, RN, will present Insulin, Why I May Need It. On Thursday, May 11th, from 7 to 8:30 p.m., Washington Hospital will host Celebration of Life. This event will feature stories of survival and hope for cancer survivors and their families. The event is co-sponsored by Washington Hospital, HERS Breast Cancer Foundation, Palo Alto Medical Foundation, and the American Cancer Society. The Washington Hospital Healthcare Foundation Report. The Washington Hospital Healthcare Foundation's annual golf tournament takes place in just a couple of weeks on Monday, April 24th at Castlewood Country Club. Held in memory of longtime Fremont businessman Gene Angelo Pisano, the tournament promises a day of great golf and fun surprises. Proceeds from the event will support surgical services at Washington Hospital. The tournament is expected to sell out, so reserve your foursome soon. To inquire about participating, please call Washington Hospital Healthcare Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District board members attended the Alameda County Special Districts Association's annual dinner on March 23rd, the Friends of Scouting kickoff breakfast on March 24th, and the Indo-American Community Federation's Unity Dinner, also on March 24th. Board members also attended the Fremont Chamber of Commerce's State of the City address, delivered by the Honorable Lily May, Mayor of Fremont, on March 31st. And the music at the Mission's Celtic Odyssey Gala on April 7th. Washington on Wheels WOW Mobile Health Clinic. During the month of March, the Washington on Wheels Mobile Health Clinic WOW continued to serve community members at the Fremont Senior Center, Fremont Family Resource Center, and the Ruggieri Senior Center in Union City. WOW also conducted hearing and vision screenings for 119 students of the Fremont Unified School District State Preschool Program. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of March was 155. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The most viewed web pages include Employment, About WHHS, Programs and Services, and Physician Finder. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of March, Washington Hospital's cable channel 78 InHealth captured new programming, including 2 health and wellness programs titled Digestive Health, What You Need to Know, and Strategies to Help Lower Your Cholesterol, and a Diabetes Matters program called Managing Your Time with Diabetes. In addition, InHealth aired 2 health and wellness programs titled Mindful Healing and Obesity, Understand the Cause, Consequences, and Prevention, a sports medicine program named Nutrition and Athletic Performance, a Diabetes Matters program called Hypoglycemia, and the March Board of Directors meeting. Awards and recognitions. The City of Fremont awarded a Certificate of Appreciation to Washington Hospital in recognition for its commitment to the environment through the hospital's Composting for Business food scrap recycling program. Most of the food scraps from the hospital are produced during the preparation of food in the cafeteria. In fact, in 2016, the Food and Nutritional Service Department composted nearly 86 tons of food scraps. Additional events and announcements. Washington Hospital celebrated National Doctors Day by hosting a luncheon for members of the Washington Hospital medical staff in the Anderson Auditorium. The event was the organization's way to recognize physicians for their service and commitment to their patients' health and well-being. Approximately 130 physicians attended the event. Our critical care units have been participating in a national collaborative sponsored by the Society for Critical Care Medicine and the Moore Foundation since the fall of 2015. The collaborative has focused on application of the ABCDEF bundle as a method to help hospitals get better outcomes for patients. There have been 67 adult critical care units and 8 pediatric critical care units working together, divided into East Coast, Midwest, and West Coast groups. On April 11th, Washington Hospital had the honor of hosting the West Coast participants in their final meeting. Representatives from 21 of the 23 hospitals in our region were able to attend, coming from California, Oregon, Washington, and Hawaii. To briefly review the ABCDEF bundle, it includes the following elements. A. Assess, prevent, and manage pain. B. Both spontaneous awakening trials and spontaneous breathing trials. C. Choice of analgesia and sedation. D. Delirium, assess, prevent, and manage. E. Early mobility and exercise. F. Family engagement and empowerment. These elements applied together, particularly for patients requiring mechanical ventilation, assist in decreasing patients' length of ICU and hospital stay. More importantly, however, application of the bundle improves patients' quality of life after discharge. As part of the celebration, the ABCDEF bundle compliance and performance data was reviewed and awards presented. The Washington Hospital Critical Care Team received 2 awards. The first award was for their work around the early mobility and exercise bundle element, and the second was for being the top community hospital performer in the West Coast group. The critical care team will be continuing use of the ABCDEF bundle in the care of our patients. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070. And please follow us on Facebook and Twitter.
I'd just like to comment briefly on the ABCDEF initiative. Stephanie Williams and Carmen Agawili, Dr. Agawili, have worked very, very hard at this, and certainly they were not alone, as you can see from the photographs of the team assembled. We outperformed not only all the other community hospitals, we outperformed a good number of the big chains and community teaching hospitals. And I think Washington's reputation for quality is growing day by day. And we should be very proud of what they've done and proud that our hospital can provide such good care to patients and improve their chances of recovery. About the program that we had here last night, we had Alan Ashworth here. You saw his photograph. What you might not know is that he is the scientist that discovered the BRCA1 and 2 genes and did the initial work, absolutely plowing new ground for cancer care, for breast cancer. To have him here in our hospital speaking to us was a distinct honor. He is redefining how medicine will take care of cancer. In the decades gone by, our approach was to try and poison cancer cells with chemotherapy. And now the focus is on immune biology. And I think that you can see what advantages that will have for patients. Their work at UCSF is extraordinary. And We are very fortunate to be their partner, and they embraced us as their partner. They toured all of our facilities. They went to see the infusion center. They looked at all of our things, including the radiation oncology center, and we're very impressed with what we have here. What's been missing all along has been the relationship with the University Teaching Hospital that will bring clinical trials here that we otherwise never would have been able to provide access to for the residents of our district. Instead, they would be traveling away, if at all, to be part of these protocols. This is a huge step we're taking. It couldn't be more important. And I'm very proud that the Board of Directors has given us the opportunity to do this. And Pat was there last night to hear Ellen Ashworth. I don't know if you want to comment.
I was in absolute awe. I mean, his presentation was wonderful. It was inspiring, informative, and what was really amazing that he was so human, so down to earth about all of it. It gives you, it's the light at the end of the tunnel.
Yeah.
It makes you feel like there is something. I on the way home, I called and left a message for a friend of mine, and I just had to tell somebody how impressed I was with the whole presentation. And I'm also impressed with the fact that this hospital district is doing something really, really constructive, and all for the patients, the people who live right here in this community. It's amazing how this hospital district has grown. Like I said, I was in absolute awe, and I repeated it to a group of people that I saw this morning. I just had to tell people that there's good news on the horizon, and it's happening right here in our hospital district.
It was a pretty big night for Washington. It really was. It was a thrill, an absolute thrill. And, you know, I think about how we got here. And we had a board that was courageous enough to stand up to the industry experts 30 years ago and not listen to them. Basically, they were telling you that district hospitals had no future, you should sell yourself to investment bankers, and we'll have a legal team here at ACHD teach you how to do just that. And that was the long and the short of what they had to offer for board education. And we had a board that was smart enough to say no and to build a separate reality for ourselves. Mike was certainly a big part of that in those early years. And we kept a good, sharp strategic plan in focus, and here we are. And instead of having a partner that wants to acquire you, strip down all your assets, steal your medical staff and move them someplace else, which is very typical of what the Sutter system has done. And now you are watching a community in Berkeley lose their hospital because of it. They made that decision years ago that they weren't going to seismically retrofit that hospital. And it was a decision based on the desire for market domination. And so now Berkeley will lose their hospital. Instead of selling ourselves to somebody else, this board stood up and took the risks of not doing it. And now we have a partner that isn't interested in eating us whole and breaking up all the assets and selling them off or closing us down. Our partner is interested in the right things, and they are interested in sharing their research, their science to improve patient care. They are sending only their very best doctors down here. It is nice to have a real partner, and I feel like we have that in UCSF. At times, the partnership's been frustrating, but in the balance, when you review these past 4 years, they have been an outstanding partner, and last night I felt very lucky to be their partner. And I hope I hope the board gets a chance at some point to meet Alan Ashworth. He's amazing, absolutely amazing, and I really do believe we are at that critical inflection point where how cancer is dealt with is going to change, and the focus will move away from chemotherapy and into immune biology. It's going to be extraordinary to watch. Now I'd like to introduce you to the Employee of the Month, who is also a very important person at our hospital, and that's Nari Chavez. He is a decision support analyst, and he's our April Employee of the Month. He's been working for our hospital for the past 8 years. He said that working in the healthcare industry was an unexpected positive experience, and what started as a temp job led to a 20-year-long career. He has great attention to detail and expert technical skills, which are appreciated by everyone that works with him. He was very instrumental in the installation of Strategaz, which is our decision support system. He frequently helps his coworkers managing to step up and be there before he's even asked, and will gladly volunteer if he's needed to support the team or a special project. He's a rather terrific employee. I guess that's just a simple way of putting it. When he's not working his analytical magic for us, he can be found kayaking at Quarry Lakes, cycling along the Alameda Creek Trail, relaxing in his backyard pool, or spending time with his family. He and his wife like to go out to dinner and spend time with their children. And to congratulate him, we're very lucky to have him with us. He's a wonderful member of the team.
Indeed. Thank you, Nancy. We'll now move on to our Lean Kaizen report, given by Donald Pipkin and Elizabeth Kirchen.
We're also going to have Dr. Bettina Kirkjohn here, who has become a major part of our Kaizen promotion office. Who's going first? Okay, thank you, Dr. Kirkjohn.
So good evening. Thank you very much for letting us come and update you about what's been happening in Lean. Pleased to be here again. I'll just start by going over what's been happening with our value streams and our improvement work. Then we'll talk about some of our other programs that we have going on, our education modules, our leadership development, and what are the next steps. And one of the things about Lean is that a big focus has been on our improvement work. And even though I'm the person who is up here and John Pipkin, we're going to come up and talk about this, really this is not work that we are doing. This is work that the hospital staff are doing, the leadership are doing to really move quality forward in the hospital. So it's really exciting for me to be part of that. So we've completed 5 service lines. You can see them here. We have 2 service lines that are still active, patient safety and imaging. And then we are going to be introducing 2 new service lines this year, perioperative services and our obstetric inpatient services, which since I'm OBGYN, it's very near and dear to my heart. I've been really excited to start the OB services unit. And then we're hoping to put in, initiate 2 additional value streams for fiscal year 2017 and 18. And there's active participation by the leadership in deciding what those 2 value streams are. So stay tuned for that. I'll go over the value streams and what's been happening with the workshops. There's a lot of work. It's really tough to, you'd be here for hours if I had to call out every single improvement project that's been done. So I'll just kind of give you some of the highlights. Supply chain, this is one of our 3 non-clinical areas. It really centered around improving the processes in the central supply unit area, as well as delivery of supplies to the floors. And this area, even though it's a non-clinical area, it really makes sense to focus on because, when the clinical staff has the supplies that they need, they have them where they need, when they need, they have certainty that those supplies will be there, it frees them up to really take care of patients and provide quality care. Lots of work in this area. Give you some examples. So one of the examples that they worked on was reducing the call volume from the 4 West unit to the supply room. So why is this important? Well, every time a nurse on the floor would call the supply room, they were not just calling to chat, right? They were calling because there was a supply that they needed. Either they didn't think, and for some reason they didn't think they had it. Either they couldn't find it, it wasn't there. And so every time that phone call went out, it was there would be a delay. The nurse would be waiting for the supply that she or he needed. The patient might be waiting too if that supply related to the patient care. And then, of course, the storekeeper would be interrupted from their usual work to bring something up. So by improving processes to reduce that call volume and making sure that supplies were there instead of the nurses having to call down, that really allowed the nurses to spend time doing what they love to do, which is taking care of patients. Our inpatient Kaizen workshops were focused on 5 West. That was our model unit. And it's sort of interesting, this work that's done in 4 West. I hear so often from nurses on other units saying, you know, when are you coming to our unit? When are you doing 6 West? When are you doing, 3 North? And even some work on 4 West, a nurse today said, well, what about the other 4th floor areas? So lots of clamoring to be part of the Kaizen work. So 6 workshops. A lot of these workshops were very nursing focused. As we know, nurses are really front and center of patient care, and so we really wanted to help optimize their processes, allow them to work more efficiently, because they are really, in many ways, the face the patient sees for a lot of their stay. And of course, while Washington Hospital is a great hospital, I think it's pretty fair to say that our patients who are with us really only want to be here long enough to get their needs taken care of and get better and go home. So we really wanted to improve processes around that. So and really free up our nurses' time to take care of the patients. So an example of something that was done was looking at the medication preparation process. So through the improvement work, the team was able to decrease the amount of time it took a nurse to prepare a medication. And so this freed up time, and so instead of the nurse taking time to prepare the medication, this was time that the nurse actually got to spend with more frequent rounding on the patients and taking care of the patients, and really kind of goes right along with our patient first ethic. We also worked on, those teams worked on communication issues. So one of the things that happens in an inpatient unit is you have a nurse on one shift, and then when that shift is over, that nurse will hand off the patient to the next nurse who will be taking care of the patient. And so, of course, handoffs are very important. We want to make sure that the whole team knows exactly what's going on with the patient. But by streamlining that process, making some standard work and standard processes, we were able to decrease the amount of time that took. And so instead of the nurse spending time doing shift-to-shift handoff, they were actually able now to get to the patient's bedside faster and get to patient care faster. In addition, they were able to go home. So instead of finishing the shift and then having overtime to stay and hand off to the nurse, they were actually able to go home on time, which people like. They want to spend time with their families. And also the institution doesn't necessarily want to have all that overtime. So that was a positive gain. Our emergency department, we completed 7 workshops. And, again, as with our inpatient units, we have a great emergency department, but people come in with the emergency department, they really only want to spend the time there that's necessary to get the care they need, get their problem taken care of, and then either be dispositioned to go home or go to the inpatient unit if that's appropriate for them. So a lot of the work was looked at getting patients through efficiently and in and out of the emergency room, getting them the care they needed in an efficient fashion. So, and a lot of this work was done really by organizing the workplace, making the workplace efficient, putting in standard work and standard processes so that patients were moved through their visit efficiently. Revenue cycle. So this was another one of our non-clinical areas. And of course, revenue cycle is very important to the financial health of the hospital. And those of us that are in the clinical world, like myself who's a physician, I really appreciate the financial stewardship of the hospital that we are, that keeps the hospital here so I can actually do the work that I love to do and take care of patients. So that work is very important. So with revenue cycle, again, the part of the focus was that, you know, we want the claim to spend the least amount of time as a claim. We want it to be processed efficiently, processed correctly, get to the payer so the payer can pay the hospital, and that's money that comes back to the hospital. And so a lot of the work was looking at how a claim goes through, where it gets held up, and trying to improve those and shorten those times. So, for example, they looked at the OR accounts receivable and were able to shorten the days, those accounts receivable days, and so that puts money back into the hospital faster. Another example that they worked on was charge capture for supplies. So we have a system where there's a yellow sticker that gets pulled when something is used in the hospital, you know, a supply is used. And so by improving processes and standardizing and improving those processes, they were able to actually capture more of those yellow stickies, which then were more charges that were captured, with an estimated net revenue increase of $300,000 for the year. Patient safety is another value stream, and this is a really important value stream. This patient safety area deals with what happens when there is a safety issue in the hospital. How does the hospital respond? And by really looking at some of these processes, it will allow us to respond faster and more efficiently than we already do. And again, really comes in right in play with our patient first ethic and wanting to have our hospital be the highest quality. A lot of this work really looked at thinking about algorithms of response, developing toolkits, developing tools that can be used by the staff in response to a patient safety concern. And this is really still a work in progress. We have another workshop still to go, and then when all of this is done, then all of this toolkit will then go to the leadership for review and evaluation and implementation. And one of the things that I've loved about the patient safety workshops is that it's really been very multidisciplinary. In these workshops, we've had the leadership, we've had people who are involved in patient safety, we've had physicians, we've really gotten a huge amount of expertise all coming together to say, you know, how can we really look at some of these processes so that when there is a patient safety concern, we can work as quickly and efficiently as possible to get that resolved. The Women's Center, another team that did a lot of work really focusing on the patient experience through the Women's Center, the flow of the visit, a lot of work around communication. So lots of things done in these workshops. An example is we were able to decrease the amount of time a patient spends during their visit in the Women's Center for a pre-surgical needle placement or Savvy Scout placement. And as you can imagine, you know, a patient who's coming up planning for surgery for a breast cancer, that's a very high anxiety, high stress event for them. So instead of having them spend a lot of time with that appointment, we want to get them into our center, cared for well, out of our center, so that they can do whatever else they need to do to prepare for surgery, spend time with their family, get that support. Imaging is the last workshop I want to talk about. We've done 3 workshops in this area. Imaging is, can be one of the bottlenecks for us, because many of our patients end up having imaging studies, so CT scans, ultrasounds, and often the imaging is really pivotal to patient decision making. So again, a lot of processes involved with trying to get patients efficiently into the imaging center, have that study done, and so that they can then move on to the next phase of their care. And of course, the inpatient imaging department ties in with a lot of other areas in the hospital. So patients come from the inpatient units, they come from the ED. So an example of work that was done was response to surge. So when the volume goes up in the emergency department, processes in place for the imaging department so they can accommodate that extra volume and still get that turnaround time done really efficiently. So I want to turn it over to Don Pipkin, who will talk to you about some of our other programs that we have going on.
Thank you. So I just want to talk about some of the other activities we're doing. We continue our education opportunities in Lean. As you know, we have our certification pathway, which is 12 to 18 months, really immersive in Lean, and it involves didactic education, leading workshops, and then certification. We have 22 staff and physicians currently certified. We also have an intensive pathway, which is a 5-day, what we like to call a boot camp. We're actually holding one this week. We've had 71 attendees for that as well, and we have more sessions scheduled for fiscal year 18. We actually have Washington staff that have been certified to teach those courses as well. We also offer a CME and CEU for physicians and nurses as well. We also have a new employee orientation video and question and answer session for all orientation, and then for new RN graduates as well. And then new in 2017, we'll be starting on competency pathway, which is really a 2-hour burst of education, just get people familiar with the Lean concepts. We've also begun the implementation of Lean leadership. The goal of Lean leadership really is to embed the tools and the continuous improvement philosophy of the Toyota management system into vertically and within vertically integrated management teams. So we've completed this training for the first cohort of attendees, which included the Women's Center, the Emergency Department, excuse me, and the executive team. We also now have weekly report outs at the visibility walls. Where really the associates and the director or the manager of that department go over their continuous improvement activity, discuss what they're working on, if there's any barriers that they need assistance with, et cetera, so they can continue their improvement efforts. And then we've also implemented a daily wall that the manager and the staff meet with, so they can talk about their improvement efforts and they put forward improvement ideas for the week as well. So really this helps really integrate those Lean principles into the daily management within those departments. And this is a picture showing the daily visibility wall and weekly visibility wall as well in the Women's Center, and it's located near the break room. If you ever want to go take a tour, please let me know. We'd be happy to show you those as well. And we have another cohort coming up next year for Lean leadership as well. We've also started testing and developing a return on Kaizen tool to better measure the returns from our improvement activities. It's in development with Rona Consulting Group, which is the consultant we're working with. We're one of the beta test sites. And really the purpose of this tool is to ensure that we're tracking and measuring the return on our improvement work, and also to ensure that we're targeting the metrics with the greatest impact on patient value, quality, safety, and the finances as well. So this is in development that we'll be rolling out in the next year. So to summarize some of the KPO successes, I think the return on Kaizen tool that we're developing will be really powerful. And the Lean leadership is really about that culture change and driving and changing that management system. Kaizen workshops continue to motivate the frontline staff. Everyone continues to love to participate in those. And we've completed 18 workshops in this fiscal year so far. As I mentioned, we have 22 staff who are certified. And we continue to roll out the Lean activities to other departments. As Dr. Kirkjohn mentioned, there was a lot of work done on 4 West. And we've started to roll some of that work out onto the other nursing units as well. So the RN shift-to-shift handoff, ED to inpatient handoff, RN and CNA huddles. A lot of the standard work has started to roll out to 3 and 6 as well. So that'll continue to happen, as has some of the supply chain work. So next steps for the coming year, as Dr. Kirkjohn mentioned, we'll start some new value streams, and we'll determine more to start as well. We'll continue Lean leadership with the second cohort. Also something else which is 3P, which is it's production, preparation, and process. And that's really a creative design process with the goal of developing processes and operational workflows that best meet the needs of the patients and the staff. And that's something we're looking at potentially using to assist with and inform the transition to the Morris Hyman Critical Care Pavilion as well. We've also been networking with other Bay Area healthcare systems that had implemented Lean. So we had a team go up to San Francisco General Hospital a few weeks ago, and I think that was a really productive trip, and we'll continue to do that and learn best practices within the area. We'll continue the ongoing training for management staff and physician leaders as well, and of course we'll continue the Lean certification process. So a lot of good work ahead for next year. With that, if there are any questions, I'm happy to answer them.
Great. Any questions for Donald or Dr. Kirkton?
Guys are rolling right along.
Yeah, it's really good to see the Lean procedures being put into place and embedded in the culture of this institution. I think that's going to pay
Thank you.
great result. It'll be very interesting to see the ROK results in the years ahead.
Well, yeah, we're excited to be developing that over the next year. I think it'll be great.
Very good. We look forward to that. Thank you. Okay. Ed Fay and construction report.
Thank you, Dr. Nicholson. Okay, so our latest monthly advancements. One thing I would point out on our schedule is still going along, and the work in the building is progressing pretty well. There's been a few things that have been delayed in terms of completion, but Rudolph and Sletton has done a good job of resequencing work, so we're still moving along on time as far as the schedule goes. The other thing that's been added to this, as you can see down at about the middle of the page where it says Change Order 67 loading dock, that is, we had a recent approval back at the beginning of the year for the connecting corridor there, and so that's been sequenced in here, and you can see that they are anticipating that to be completed along with final completion and then some wrap-up work after that is done. So our schedule is holding. You can see again, as we start at the bottom part of the building, the basement is getting more and more of a final look to it with the ceiling grid going in, and you can see things like fire sprinklers, smoke detectors, things like that also being put in place on the basement floor. The other thing that's begun is the installation of the elevators, 1 through 4, which are going to be in the main lobby and off the back of the main lobby. There's also one going into the emergency department. And this gives you a look at some of the steel that's going in place, the steel supports for the elevators. So that's moving along in sequence. This gets you a little bit of a look on the first floor, and low voltage cable going in. Here's painting going on in the ED area of the first floor. As you get up to the second floor, you're looking into the individual rooms in the critical care area and the windows outside. You can see not quite as far along, but good progress there. And this gives you a shot that you're getting a little bit more finished look out on the porches as well. You've seen electrical updates here. You can see we're starting to get finalized here with electrical, and within the month we'll be cutting over and getting this. Right now this is getting fed from temporary power locations, and we'll have to do basically we'll have to go on some emergency power here at the hospital in the coming month as we switch this hospital, the Hyman Pavilion, on the main electrical breakers coming in from the central plant. This gives you a look at the skylight. You might see some of the steel going around there. There is protective sort of glass on the upper floors so that people are protected from the atrium, and you're starting to see that also be introduced to the building. This shows you up in the penthouse. We've got the elevator mechanical equipment going in. And this is showing you that they now can't really see it real well, but they have painted out the locations of the additional loading dock, the corridor, etc., that's going to be connecting the two buildings. So that work is being priced out, and we'll be starting that shortly. This gives you a view of where we are today. Any questions? We're still, as you can see, holding on our
Ed,
on our schedule.
I had a question on the PERT chart. It showed that the commissioning process looked pretty long. What is all involved in that? Because it sounds like that starts this summer.
Yeah. It's everything. It's basically making sure that all the electrical, mechanical, fire, everything is functioning, all the connections between the plant and that. So they have to go and basically check every connection throughout. So it's a very sort of detailed process. And they've already started some of that work, but the majority of it happens as the building is getting completed.
Okay. Good. Any other questions?
Must take a little bit of courage to turn that switch on.
Well, I would say that we keep track of all the inspections, and I think it's something like 97 or 98% of the inspections that occur, and there's been thousands of them so far, pass on the first time around. So I think the quality of the workmanship is really good on the job. So yes, we're courageous and think that we're going to be able to do that without issue.
I'm just waiting for his usual statement of...
It is still on time and on budget. It's it's as we get the connections and things like that, it's going to be a challenge. But yes, it's all still going on time and on budget.
Thank you very much.
That's what I wanted to
you.
hear.
All right. Chris Henry, Finance Report.
Good evening. Tonight we'll be looking at Washington Hospital's operational and financial results for February 2017. Average daily census for the month was really high at 200.5. We had budgeted for 183.1 in February, which is always one of our busiest years of the year, or months of the year. But this February was really busy. We had 1,006 admissions. We'd expected 1,063, but our patient days were 490 above budget at 5,616. I think that's really a reflection of the types of patients we were seeing, respiratory, neuro, patients that had medical conditions that required long lengths of stay. Our outpatient observation days for February were 62 below budget, and as I just mentioned, our average length of stay was 5.46. We had expected an average length of stay for the month of 4.82 days, so those folks were staying a long time. Looking at utilization, case mix index for the month was a little bit below budget at 1.54. We expected 1.566 in the budget. We had 120 deliveries in February, 24 below the budget of 144. Surgical cases were 32 below the budget at 345. That included our joint cases that were 4 below budget at 143. Neurosurgical cases were 13 below budget at 17. Our cardiac surgical cases came through strong, 6 above budget at 18. Cath lab procedures for the month were 34 below the budget at 377. Our outpatient visits in February came in at 6,322. We'd expected 7,093. Emergency room visits for the month were 4,188, about 520 below what we expected in the ED. But by historical standards, still pretty busy in the ED for February. Quick look at our cath lab activity for the month. Peripheral vascular and cardiac procedures kind of flip-flop who's leading the way from month to month. This month it was cardiac procedures at 42% of the activity, followed by peripheral vascular at 40%, and rounded out by non-vascular neurointervention. Looking at productivity, productive FTEs for the month were 34.3 below budget at 1,298.6. We had 168.6 non-productive FTEs for the month, giving us total full-time equivalents at 61.4 below the budget at 1,467.2. Our FTEs per adjusted occupied bed, which is our productivity measure, came in at 5.69. We had budgeted for 6.27. I think, again, that's with the high level of activity, it's as much a reflection of the tight labor market in the Bay Area and trying to get nurses to cover shifts. Our clinical staff was working very, very hard in February. Moving into the financials, total patient revenue. First, we'll look at our GASB format, which is the format we use for our audited financials. Total patient revenue came in almost $3.5 million above the budget at $181,973,000. Our contractuals for the month came in high at 78.36. We continued to see the trend that had kind of started in February with very high level of government-sponsored patients. Our government-sponsored patients in February made up 76% of our gross revenue. Generally, we see about 70, 71, 72% government-sponsored patients, and some of that was driven by Medicare. Some of the diseases that were going on in February hit the elderly, but a lot of that is coming from Medi-Cal HMO, and Medi-Cal HMO is where the expansion population from the Affordable Care Act is receiving their benefits. And I don't have any hard evidence to this, but we've seen that number slowly increase since the election, and it sure appears that folks are afraid they're going to lose their benefits and they're coming to get services. So we ended up February with actually net operating revenue $2.273 million below the budget at $40,729,000. Operating expenses for the month, though, came in a little over $2.1 million below budget at $38,624,000. Big driver there was bad debt. Our provision for bad debt and charity was about $1 million below budget. We also had favorable variances in the area of purchase services and pro fees, and our marketing and software maintenance expenses were significantly below budget as well. So, and that's marketing was due to we're just getting ready to roll out a big marketing campaign, so it's a timing thing on marketing. So we ended up the month with an operating bottom line actually pretty close to what we had expected in the budget, about $159,000 below budget, a little over $2.1 million. Non-operating income for the month came in $396,000 above the budget at $2,073,000. We did have a $196,000 unrealized gain on our investment, and our other income, which is largely our rental income, came in $328,000 above the budget at $390,000, and again, that's additional revenue coming from the Fremont Office Center. So we ended the month with a total bottom line from a FASB perspective, actually $237,000 above the budget at $4.178 million. Take a quick look at the Financial Accounting Standards Board presentation. This is the way the financial markets might adjust our financials to take a look at us. The operating bottom line doesn't change at $2.1 million. We pull out our unrealized gain in our investments, our property tax revenue that services our general obligation bonds, to come out with non-operating income from a FASB perspective, about $251,000 above budget at $533,000, and total bottom line about $92,000 above the budget at $2.638 million. So, are there any questions on February's results?
Chris? Okay, thank you, Chris. Operations?
This is the preliminary results for March. From the standpoint of volume and activity, they're spectacular. But I will warn you now, from the standpoint of payer mix, it may be a sign of what's to come, and it's not good. In terms of gross revenue for March, we were above budget by $13.9 million at $199.1 million, and higher than March a year ago. The inpatient gross revenue was $11.9 million above the budget at $150.4 million. The outpatient gross revenue was $2 million above budget at $48.6 million. The major drivers of the favorable gross revenue variance include patient days that were 14.4% above budget, which drove our room and board revenue higher. The increases in census also drove ancillary service volumes and revenue higher, and this resulted in a favorable revenue budget variance of $8.3 million. It's 10.6%. Cath lab procedures were 31 in number above budget. Key census statistics include an average length of stay of 5.62. Our budgeted call for 4.71, so it was higher than what we had budgeted. Therein lies a bit of a problem as well. The average length of stay was 30.1% higher than in March a year ago. The outpatient observation days were 18 below budget, and that is a good thing. Average daily census of 195 was 25 above budget, or a 14.7% variance. The increase in the average daily census was partially driven by the longer length of stay, and that's important to keep in mind. We had a higher number of cardiac, medical, and respiratory cases, and they tend to contribute to the longer length of stay. Admissions of 1,163 were above budget by 43. The patient days of 6,033 were above budget by 759, or a 14.4% variance. And they resulted in room and board gross revenue that was $3.9 million, or 10.3% above budget. Our patient days in March were 1,124, 22.9% higher than March a year ago. Surgical trends. Our cases in March numbered 413, and they were below budget by 3 cases. We had an unfavorable variance for surgical services revenue, approximately 1.3%, or $466,000. Surgical cases in March were 11 higher than March a year ago. Inpatient surgeries were 16 below budget at 317. Outpatient surgeries were 13 above budget at 96. General surgical cases were above budget by 4. Cardiac surgeries were above budget by 1. And these favorable variances were offset by neurosurgical cases being below budget by 1. So you can see that the neurosciences program has a wallop of an impact on how we play out our finances. The joint replacement surgeries were also below budget by 7. Cath lab procedures for March numbered 445, and they were 31 cases above budget. The inpatient lab procedures were above budget by 53. The outpatient cath lab procedures were below budget by 22. Cardiac procedures were above budget by 43. Neuro-IR procedures were above budget by 1. And these favorable variances were offset by non-vascular interventional radiology procedures that were below budget by 5, and peripheral vascular procedures that were below budget by 8. Deliveries for March numbered 146. We were below budget by 2 deliveries. And when we compare this month with a month the year before, we were 5.8% fewer. Non-emergency outpatient visits of 7,749 were below budget by 159, or 2%. Yet these visits were higher than March a year ago. The budget anticipated that the prenatal diagnostic clinic would have been opened in November and accounts for 149 visits of the variance. We are hopeful this clinic is going to open in June. This is one of the activities that we are engaged in with our partners at UCSF. And this is an important service because it means young mothers won't have to leave the Tri-City area to get advanced care when it's necessary. So we're really hoping that we'll open in June. I want you to know the opening has been pushed back due to delays in permitting by the city of Fremont. Cardiac rehab visits were also part of the non-emergency outpatient visits picture. We had 122 visits that came in above budget. The infusion center visits came in 82 above budget, which I think is a direct reflection of the presence of FTEMI and Lee. OB visits came in 26 below budget. Lymphedema visits came in 85 below budget. And I think that's something we need to check on because that's one of those essential services for cancer patients. Lab visits came in 41 below budget. Emergency room visits, we had 174 below budget. If that means they got a breather, boy, did they earn it. They have really been working hard this winter. And they came in 178 lower than March a year ago. Our productivity indicators were above budget by 4.8%. Non-productive FTEs were also below budget by 27.3%. Total FTEs of 1,470.4 were above budget by 9.8 FTEs, or 0.7%. Productive FTEs per adjusted occupied bed came in at 5.16, and this was 7.7% below the budget. Total FTEs per adjusted occupied bed of 5.70 was 11.4% below the budget. I would just like to comment that this is more likely a reflection of the absolute unavailability of people through the agencies to supplement staffing when the census becomes very high, and they're just not available. It's difficult not just for nursing, it's also true for respiratory, and our employees have had to work very hard this winter, and we are beginning to discuss strategies of how we might handle this a little bit better going forward. These companies want you to sign guaranteed minimum contracts, and you have these folks on your payroll whether you need them or not. And so it's a juggling act, and we're going to have to sit down and sharpen our pencils and figure out what we can do, because we can't continue to do this to our employees. It's just too hard on them. Our other operational statistics that you might be interested in, the outpatient surgery center had 520 cases in March, 10 cases below the budget, and our clinic visits for the month totaled 4,079. They were below budget by 528. The Washington Urgent Care Clinic was down by 131. The Newark Clinic by 391. Warm Springs, 144. The Ohlone Clinic was down by 28 visits, and the Nakamura Clinic by only 96. But clearly, we're going to have to take a look at those volumes and see what's happening. Payer mix. Here we go. It's unfavorable for March. Government-sponsored patient revenue made up 74.9% of total gross revenue. It's a hair's breadth away from 75%. And I think when you get there, you have hit the point of diminishing returns. Our budget had called for 71.1%. Our HMO revenue was 2.6% of gross revenue. We had budgeted 3.5%. PPO revenue was 20.8% of gross revenue. Our budget had called for 23.4%. Private pay revenue was 1.7% of gross revenue. compared to a budget of 2.0. But what you see is Medi-Cal encompassing the people that were self-pay. Key financial statistics for the month. The days cash on hand for March was 154. This was driven in large part by having 3 pay periods in the month, so we expect to see it pop back up next month. The days in accounts receivable were 56. That is pretty good. That means business office has been working hard. There were $327,312 in charity care applications that were pending or approved for March.
Here mixes the challenge for the decade ahead. Okay, we've got some action items, and they'll be presented by Director Wallace. Item A.
Mr. President, in accordance with district law, policies, and procedures, I move that the board approve the establishment of the debt issuance policy to provide guidelines and procedures for the issuance of debt obligations of the district, and to authorize the Chief Executive Officer and the Chief Financial Officer to take such actions as may be necessary to ensure that the district complies with its internal control procedures, which are consistent with the requirements of state law, to ensure that the proceeds of any debt issuance are directed to the intended use.
Thank you. Do we have a second?
Second.
Second from Director Stewart. Nancy, you want to
Be happy to
outline
speak to this. We're asking the board to consider adopting the debt issuance policy in order to comply with the new laws that have gone into effect this year. The board adoption of the policy formalizes what has been the internal policies of the district for many years. So it doesn't really change much. The policy applies to long-term debt issuance of all kinds. The policy outlines the district's goals related to debt. It also sets guidelines for the methods of debt sales, the key factors to consider when structuring debt offerings, and the selection of professional services related to debt issuance. Finally, it requires the CEO and the CFO to maintain an internal control structure to ensure compliance with ongoing legal, tax, and continuing disclosure requirements. We do that already in part through the external audit that is presented to the board at fiscal year and after PricewaterhouseCoopers has reviewed everything. We also have an internal audit function that will be looking at these things pursuant to this policy.
Great, thank you. Any discussion? If not, Dee, could you call the roll?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Motion passes. Item B.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the Chief Executive Officer to enter into the necessary contracts and proceed with the purchase of the hardware, software, and implementation services for a continuous interface to Cadwell EEG for an amount not to exceed $31,343.
Thank you. We have a motion. Do we have a second?
Second.
Second from Director Stewart. Nancy.
This connects our EEG system with our Epic system. And I think it really is essential that we do this.
It's so nice to be able to, within Epic, get the data you need.
Yeah,
Yeah.
it is. It
really
will be very
enhances
helpful.
care. Yeah, good. Any other discussion? Okay, Dee, if you could call the roll, please.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Thank you. Motion passes. Item C.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the Chief Executive Officer to enter into the necessary contracts and proceed with the purchase of hardware, software, and implementation services for IntelliSpace perinatal upgrade, SABA Cloud Learning Management System upgrade, Midal Plus, and Statit reporting upgrades, and 3M chart script update
for a total amount not to exceed $512,806.
Great, thank you. We have a motion. Do we have a second?
Second.
Second from Director Stewart. Nancy, this looks like a potpourri of upgrades.
Yes, it is, and it's connecting them.
Things we have to have.
Yeah.
Okay. Any discussion or questions? If not, Dee, could you call the roll?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye. Okay, motion passes. Item D.
Mr. President, in accordance with district law policies and procedures, I move that the board authorize the chief executive officer proceed with the purchase of 8 laundry carts for a total amount not to exceed $68,461.67.
Thank you. We have a motion. Do we have a second? Second from Director Stewart. Laundry carts, Nancy.
We've been preparing for surveys, and we're expecting 2, one from the state of California with a brand-new survey, and, of course, the other being our Joint Commission survey, which we expect momentarily. Actually, both of them. And it was noted as we were going through our mock surveys that our laundry carts are either damaged from many years of use or have wood on the base, which does not allow for proper cleaning. And in, I think, an abundance of caution for infection control issues, that it is important that these 8 carts be replaced.
Clearly, we've seen from our quality report today that infection control is a critical aspect of this facility.
And these are being substituted for another item that was in the capital budget for the laundry.
Good. Thank you, Nancy. Any discussion? Questions? If not, Dee, could you call the roll?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Okay, motion passes. At this point, we're going to adjourn to closed session. Okay, we're going to reconvene to open session and announce that no reportable action was taken in the closed session. We have one additional action item tonight, and that's item E, which will be presented by Director Wallace.
Mr. President, in accordance with district law, policies, and procedures, I move that the board accept by minute motion the bid received from City Building, Inc. for the prenatal diagnostic clinic project for an amount not to exceed $536,390. In addition, I move that the board increase the construction budget for this project by $170,000 and direct the chief executive officer to execute the contractual documents necessary to complete this project.
Thank you. We have a motion. Do we have a second?
Second.
We have a second from Director Stewart. Nancy.
The budget was adjusted when the city of Fremont dictated accommodations in the construction plan that amounted to $170,000. So that's where it sits.
Yeah.
If we want to build it, we got to do it.
Yeah, and we need this prenatal diagnostic clinic.
Yes, we
Yesterday.
do. Yesterday, you're right.
Okay, any other discussion? Okay, Dee, if you could call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Motion passes. I believe there being no further business before this board tonight, this meeting is adjourned.